At this time, we'll introduce Dr. Biersack.
Yeah, thanks, Tyler. And now officially good afternoon, everyone. I'm Dr. Matt Biersack, President of Mercy Health St. Mary's, and I want to thank you for joining us for today's update with West Michigan Health Systems. I'd like to start by just thanking our partners that are on today's meeting. I see Dr. Daryl Elmucci, the President of Spectrum Health West Michigan, Dr. Peter Hahn, the President and CEO of University of Michigan Health West, and Rick Baker, President and CEO of the Grand Rapids Chamber. Today, we're going to run through a few things. We'll update you on the current state of our health systems. We'll provide an update around variants. We'll talk about vaccine efficacy and safety, different therapeutic options, and the impact of the public health advisory. And after that, we'll open it up to questions from you all related to that. Invite you to please, as Tyler mentioned, type your questions into the chat feature to help facilitate. So we'll start by having each of our partners share what they're seeing at their own organizations. And Dr. Elmucci, if we could start with you as president of Spectrum Health West Michigan.
Thanks so much, Dr. Biersack, and thanks everyone for being here. I actually have a few slides to share. I'm wondering if the team can help with that. So this is the new version of our publicly available dashboard. We just updated it yesterday as far as the format, and the data is from today. And as you can see, the grand total number of inpatients we have in one of our hospitals with COVID-19 is a very high 455. I'll show you on a later slide. This is almost our record. Our record was set 2 days ago, and there's a little fluctuation. But most challenging for us, you can see, is the ICU numbers. We have 126 adult ICU patients and 1 pediatric ICU patient. This is beyond capacity, and as we've talked about for a number of weeks, those numbers keep going up. Additionally, if you look at our lab testing, we have had a rolling average positivity, that 7-day you see there on the bottom section, that really has been in the 23 to 25% range now for about 2.5, 3 weeks. This is unprecedented here in West Michigan with this high volume of testing, and this is really driving future infections, future hospitalizations, and unfortunately, future deaths. And then finally, I'll call to your attention something that we were proud of this past week. We just crested over 10,000 recoveries. Those are 10,000 patients admitted to one of our hospitals since the pandemic began with COVID-19 who successfully left the hospital. So in spite of all the challenges we've had, something nice to celebrate. If you can move on to the next slide. Oh, one back. Yeah, thank you so much. And so this is a busy slide, but what I'd like to show you is the following. The blue curve is where we are now. The red curve is last Thanksgiving, essentially the first surge that we all saw here in West Michigan. And the green curve was the spring surge we saw earlier this year. What you notice about the green and the red curves, they both went up relatively quickly and then came down relatively quickly. What you can see about the blue curve and what has taxed all of us here in West Michigan is we've had this very gradual but steady climb up really for over 2 months, nearly 3. And then about 2.5, 3 weeks ago, a sudden jump up. We're now well beyond anything we've seen before here in West Michigan with the number of hospitalized patients, at least at Spectrum Health. And then you can see a little up and down, and 2 days ago, we were at our high point. I wish I could say we're on the way down, but as you can see by these curves, there's often a little fluctuation day by day. And so with that, I'd like to turn it over to Dr. Peter Hahn, the President and CEO of University of Michigan Health West.
Thank you, Daryl, and just wanted to thank you and Matt for your partnership and the partnership and collaboration of all the teams through all of this. So if I could pull up the slides there. So this is, absolutely, I think, a time of reckoning for healthcare, especially on the hospital side. This prolonged Delta surge combined with, staffing shortages, exhaustion, it's a very difficult time. And yet I think we all hold the line for the community. So, we at UM Health West have been at about 90% of our staff bed capacity for almost 3 months. Much similarly, we hit our highest COVID inpatient census at 80 at the end of last week, and we've been hovering between the high 60s to mid 70s for probably about 3 weeks. And obviously, the vast majority of admitted COVID patients are unvaccinated. They're younger in age and tend to be sicker. And over 90% of our patients who are on ventilators are unvaccinated. And if they're vaccinated, what we're seeing is these are elderly folks with multiple comorbidities. Next slide, please. So, and these patients have a very long length of stay, often over 2 weeks, and that's causing a lot of difficulty in terms of flow within the hospital. We're having to cancel a lot of surgeries and procedures because of the staffing and the bed availability. In the last 2 weeks, we've delayed over 70 procedures. And a lot of these are very important ones that we need to get back in for our patients. And we're trying to shift more and more to outpatient procedures to take care of patients who have critical need of interventions. Next, please. And this is also affecting our emergency room where, on average, there can be a 3-hour wait, sometimes up to a 6-hour wait. And then on the other side of that, we're having difficulty getting patients to short-term nursing facilities because of their own staffing issues, transportation issues, et cetera. One thing we've employed, and I know others have as well, is this hospital at home model where at any one time we might have up to 20 patients at home using technology to monitor them. So, and at this point, I'd like to hand it over to Dr. Matt Biersack.
Well, thanks to you both. I think you'll see in our first slides here, if we could pull those up, that we're seeing numbers of hospitalized patients very consistent with what Dr. Almucci and Dr. Hahn mentioned. You can see this burgundy curve that's superimposed on the 2020 curve in blue. And much like Dr. Almucci described, we're seeing a very similar high number of patients, but the slope to get to that point has been much more prolonged. Today, what we're seeing is a 98% occupancy in our hospital overall, and we're seeing 100% occupancy in our ICU. So Dr. Almucci spoke a little bit to, the high degree of acuity that we're seeing, and that's a key difference in terms of comparing what we're seeing now to what we were seeing back in November of 2020. A couple other key differences from what we had seen previously. One is that, and if we could actually go back, one is that, between the high numbers that we're seeing today and the high numbers that we were seeing previously, we're actually providing substantially more care for non-COVID patients. And I think some of that's a result of both delays in preventative care and acute care from 2020. We're also seeing that the healthcare workforce as a whole has contracted. There's national data that suggests that maybe up to 100,000 have left the workforce, and among them, some of our more experienced clinicians. And then, as I mentioned, acuity is so much higher. We actually have an additional fleet of 10 ventilators that are arriving today to support demands in our ICU. So we've responded in much the same way that you've already heard. We've implemented our disaster plan, running hospital operations out of our incident command. We've opened an additional nursing unit to support additional patient care. We've converted COVID rooms into semi-private. We've limited visitors on our campus and adapted care models. And we've also canceled or postponed a number of different surgical procedures, as Dr. Hahn mentioned. These are joint replacements. These are back surgeries. These are bariatric procedures. These are and really present a substantial impact on people and their families. So this infographic that's shown here does a nice job, I think, of demonstrating not only the volume of patients that we're seeing, but also the breakdown of vaccinated versus unvaccinated. And this is actually a summary of Trinity, Michigan data. So it's really across all of our Trinity, Michigan hospitals. But what you can see is that the predominant number of patients in our ICUs and who are vent dependent are unvaccinated. And if we look at our Mercy Health St. Mary's data, 86% of those in the ICU this week were unvaccinated. 88% of those that were on ventilators were unvaccinated. So I think demonstrates a dramatic effectiveness to vaccines. As Dr. Almucci mentioned, our internal case positivity rates have continued to climb. I think those mirror those that we're seeing at the county level. And on the next slide, it shows just some outcomes that we've seen since this pandemic began. Now, We can see here that men and women have been equally impacted in terms of hospitalizations, but what we have seen is a shift in terms of the age demographic. We're seeing more and more people within this 20 to 44 age cohort, and particularly with this recent surge with the Delta variant. And although we've seen some just horrific examples of young people dying from COVID, there is still a strong correlation between age and other medical conditions and death from this disease. So, one of the things that these graphs, if you move on, don't mention is that just the impact that this pandemic has on people. I mentioned the impact that it has on individuals whose very well anticipated surgeries have had, but also just the individuals and families that are suffering from COVID-19, the fact that patients can't visit their loved ones because it's oftentimes not safe to do so. And I think the worst impact that we've seen from this pandemic has just been on our healthcare workers. Our staff are tired. I know they are at all of our health systems. They're desperate to a reprieve from the pandemic. So I'm going to shift gears and chat a little bit about some variants related to COVID-19, some updates about what we're seeing now and what we're seeing related to Omicron. So if we could, this slide shows that really, despite all this new focus on variant activity, we can't lose sight of the fact that Delta is still all around us. Delta is definitely the variant of the day and nearly the exclusive cause of COVID infections within our community and state. So we still have much to do in terms of curbing the impact from Delta while we await more information about Omicron. So let's talk a little bit about that because it's certainly been a source of a significant amount of news of late. So Omicron was first detected in South Africa early November, and I think there's if we could pull up the slides related to Omicron. What we experienced was that I think by late November, there were a number of different cases, actually the predominance of cases that were studied in a particular area in South Africa that were positive for Omicron. So this is of concern because it suggests that it may be more transmissible than the Delta variant. The good news is, if there is good news, that a lot of our typical tests, it looks like, will identify this as a COVID infection, but it does require advanced sequencing in order to identify this variant very specifically. But it was the predominant strain that was seen recently in the cases identified in South Africa, where the vaccination rate was, I think, only around a quarter of the population. And I think we have to give a lot of credit and recognition to those scientists that first identified this and then really brought it forward to the medical community at large. If we could advance to the next slide. It's interesting how quickly news develops, right? So this slide was pulled from on December 1st, and we can already see that it's outdated because as we now know, there has been a number of cases that have been identified in the US. There's been Omicron variants that have been detected in New York, in Minnesota, Colorado, Hawaii, I think, as of last reports, in addition to California. And there is certainly some assumptions being made that at this point, there's already community transmission, that these weren't just necessarily cases that were transplanted from across the globe. So why the concern? Why listed as a variant of concern? Well, there's quite a few mutations in the spike protein, and this is the protein that's involved with how the virus attaches to human cells. And some questions are out there. Well, could we see more reinfection as a result of this new variant and some of these mutations? Could we see that there's less effectiveness of the vaccine? Could we see that it could evade some of our therapeutic options? But I think the answer to these questions is we just don't yet know. What we have heard recently was that Pfizer leadership went on record telling Bloomberg actually that they didn't expect there to be a significant drop in effectiveness. But I think we're all seeing that it's just far too early to tell. We don't know yet if this new variant is more transmissible. We don't yet know if this new variant will cause more severe disease. And we also don't yet know whether or not vaccines will be as effective against this variant, although there's a substantial amount of speculation that the vaccines will be. The other important points to realize or to remember is to not make this or a panic too early is, again, a lot of the cases that were reported as of the first of this month were mild in nature. And again, it's still unclear, a lot of these questions around transmissibility and severe disease. And so I think one of the take-home messages is that we still have to be highly concerned about what we're seeing right now with Delta before we become fixed on the impact of Omicron. So with that, I'm going to turn it over to Dr. Almucci to talk a little bit about vaccine efficacy and safety.
Great, thanks so much. And maybe before I start talking specifically about vaccines, I might put a little why out there. So why is this all so important? And obviously, for most people, I think it's pretty recognizable. But we really, over the last few months, put so much stress on the healthcare infrastructure of West Michigan and our state that it is getting to a point that we all should be concerned. And so I'm going to give you some numbers from Spectrum Health that I'm sure are representative from Matt and Peter's institutions. 700 is the number of calls we received to accept patients from outlying hospitals within Michigan that needed a higher level of care that we've had to deny over the last month and a half. We've literally gotten these calls where it said, we need your help. We need a bigger, larger hospital, a higher level of care. And we've been so full, we have not been able to do that. Historically, we accept all of those patients. That's happening not just here, that's happening across the state. So you could be in the UP, you could be somewhere up north, anywhere else, get in a car accident and have a heart attack. And even if it's not COVID related, because the strain COVID is putting on the healthcare system, you could potentially not get the care you otherwise would. Second number I'll give you is 1,100. That's the number of surgeries we've had to defer since this particular surge began. That's 1,100 people that should have had a surgery, that their doctor felt they needed a surgery, that we've had to push off to some extent safely. But nonetheless, that causes suffering, that causes psychological trauma, and that's not what any of us want. So one of the reasons that people should care about this, even if they're not terribly personally concerned about COVID, is it could impact any other part of your health. And then when you look at the caregivers, all of us and all the folks that work with us, people are really struggling. This is needless death day after day. If you could put up my slide, I have one more, somewhat akin to Matt's slide about the state of Michigan for Trinity. This is our slide for Spectrum Health as of this week, what we're seeing regarding vaccines and inpatient stays. This week, of the 452 inpatients we had a couple of days ago, 87% of those with COVID-19 were unvaccinated. Last week, it was 91%. In our ICU, 92% of those people are unvaccinated. And of the people on the ventilator, 94% unvaccinated. And much like Peter mentioned, when you come in the hospital and you are vaccinated and you have COVID-19, you tend to be older and have other comorbidities. So younger, healthier people are showing up in our hospitals acutely ill. And I always tell folks that are hesitant about the vaccine, if I could just tour your ICU for 5 minutes, introduce you to pregnant women that are on the ventilator, introduce you to young people with kids there that are on the ventilator, potentially dying. Vaccines work. They're incredibly safe, incredibly effective, and the only way we're ultimately going to protect our community and our healthcare resources. And so with that, I'd like to turn it over to Dr. Hahn.
Thanks, Cheryl. If I could get the slides pulled up there. I'm going to just talk briefly about some COVID-19 treatments. And I think it's really important to stress, as Daryl said, the only way we're going to get through this is through vaccination, through immunization. We're not going to treat our way through this, right? But there is some good news. I think since December of 2020, we've had some monoclonal antibodies available. Bamlanivimab was the first one. We have 3 that are available at all 3 health systems. And these are IV infusions primarily that have been shown to significantly decrease your chance of getting hospitalized with COVID-19 in patients who have a severe risk for getting hospitalized. If you have underlying comorbidities like diabetes, like hypertension, obesity. So studies have shown actually about a 70 up to 85% decrease in that risk for hospitalization if you get a monoclonal infusion. The first two there, the first one by Regeneron, the casirivimab combo, and the bamlanivimab by Lilly, they're also indicated under the EUA for post-exposure prophylaxis. And then sotrovimab is actually being studied in an IM form as well. So next slide, please. Although these are great medications, they do come with some complication, right? So at this point, most of us are doing IV infusions, and you have to come into the hospital or the ED or infusion center. It takes about a half hour to an hour to get the medication, administered, and then you have to be watched for about an hour. And there's a lot going on, I think, with the county to even look at potential strike vans, where vans would go out with either IV infusion or sub-Q in terms of the Regeneron product to actually go to the patient. But there are difficulties with administering these monoclonal antibodies. Next, please. Just to give you a sense, over the course of basically since December of 2020 till now, over about a year, we've given about 1,000 infusions. And I think the important thing to see is in the last week, we've seen significant spikes in terms of the number of folks that are coming to us. And I know Daryl and Matt can speak to the same thing, that we're seeing more and more folks who want this infusion. And so with all the staffing shortages that we're already dealing with, this is a challenge. Next, please. I do wanted to finish up on, I think exciting news in terms of oral antivirals. There are two that are, hopefully coming available pretty soon. Maybe I'll talk about the Pfizer Paxlovid first, which is a protease inhibitor. And those have been used successfully in HIV treatment for a long, long time, very safely, very effectively. And the initial data about Paxlovid is very promising, right? That if you have risk factors for progressing to severe disease, again, similar things like diabetes, hypertension, obesity, that if taken within the first 5 days, this oral medication was shown to have about an 89% decrease in the rate of hospitalization and death. So very promising. And then Merck's product, which the FDA advisory panel, if any of you watched, fairly contentiously recommended for approval. We'll see what the full FDA does. It's a little less effective. Basically, it works within the cell to actually mutate the virus into a form that basically makes it ineffective. And so in a very similar study, it showed about a 30% reduction if taken within 5 days in terms of progressing to hospitalization or death. And so we'll have to see where things go, but supplies likely will be pretty limited until next year, regardless. So, and then I'd like to pass it on to Rick Baker, president of the Grand Rapids Chamber, to talk about the business community response.
Thank you, Dr. Hahn, and I thank you all for allowing me to be a part of this conference today. I appreciate the opportunity. I want to kind of add, maybe just kind of personalize this a little bit and put a human face to this issue. These are our friends and neighbors who are treating and providing healthcare to our friends and neighbors. I know we're all kind of exhausted by all of this and ready for this to be done. But COVID has really a different plan for us, and we're not done with this. And so as a business community, we're asking everyone to stay vigilant and to kind of stay the course for some of the things that we've been trying to do over the last couple of years so that we can get this behind us and be able to move forward with our lives. I would like to first thank the medical professionals in our community for the yeoman's work that you all have been doing to protect our lives and in our communities and to serve our community. It's been a big lift, I know, and we sincerely appreciate it. But you know what? Those are just words. I think the best way for us to show our thanks is to do our part. is to get the vaccination and to act like we've been taught how to provide safety for those that are most vulnerable around us, and to really do our part to get past all of this. The chamber continues to urge our members and urge the community to follow the guidelines that have been put out, for almost the last 2 years now. Stay at home if you're sick. Practice good social distancing and wear a mask, and protect those who are most vulnerable or at most risk. And first of all, and most importantly, protect yourself by staying healthy and getting the vaccine, and now your booster if you're eligible. These are not big asks. These are easy things for each one of us to do. And again, I would say it's an opportunity for us to show our thanks to the healthcare community by doing our part to get us past all of this. So we have a ways ahead of us. We've seen the data that's been shared today, but I think there's an opportunity for each one of us. And I'm sure all of us have stories that have hit close to home. I know I do. In both sides of the issue of someone that's had COVID and someone that's having difficulty receiving treatment right now because of the capacities of the hospitals. And so I know I'm going to do my part, and I'm asking my fellow citizens to do their part as well. And we're asking our business community to kind of keep sharing the message with your employees, and to share the practices and remind them of what they can do to help us all get through all of this. I'll turn this back over to Dr. Biersack.
Yeah, thanks a lot, Rick. I really appreciate you bringing the very personal impact and touch to this. I know that all of these issues that we've raised certainly deeply impact the individuals involved, from the healthcare workers to the people whose surgeries have postponed, to those that are directly impacted by COVID. So thank you for that and your comments and your support. We will move to the questions. And the first question that I'm seeing is from Robin. It speaks to the average length of stay for a COVID patient. And if so, is there a way to break out the average for a patient who does not die from COVID? And so it's a good question. I would say, as you look at the data in terms of length of stay for patients with COVID, there's a lot of variation. And that's because patients come to us in a lot of different ways. And some only require supplemental oxygen, and others require a critical care unit, and others require a mechanical ventilator. And then patients, unfortunately, have very different courses based on some of the other issues that they may be facing. And so we see anywhere from an average length of stay of 4 to 5 days for a fairly straightforward or moderate case of COVID-19 to, in excess of 2 weeks, 3 weeks in some cases, of patients that have really struggled and need additional life support. And then at times, as Dr. Hahn mentioned, patients stay within our walls for an extended period of time because it's difficult to meet their post-acute care needs. It's difficult to find the space for them to rehabilitate, or find the space for patients that have been severely deconditioned by the virus, and to move out of the walls of the hospital in a safe way. And so there can be a lot of variation around this. Your second question related to capacity, and how do we define capacity, and what does beyond capacity mean? And I thought maybe Dr. Hahn, if you wouldn't mind kind of speaking to this as we talk about capacity and numbers.
What we look at closely is staffed beds, right? And through all of this, the more and more patients that we see, our bedside nurses are actually taking on more and more assignments. So they're taking care of more patients. And even our nursing leaders, who would be doing administrative time, are actually taking direct care of patients. So, you may have 100 beds, you may have 1,000 actual physical beds, but it's really, the way we look at it is, how can we staff the number of beds safely? And so that is, I think the question is appropriate in that it can be a moving target. especially right now.
Thank you for that, Peter. The next question is from Scott. Scott, maybe if you could unmute and expand on this. Your question relates to Grand Valley as a potential site, and I thought maybe Dr. Omuchi could help address this.
Sure.
Good afternoon. This is Patrick Center at WGVU. Everybody uses this Zoom, so Scott's not in on this call. Yeah, I'm just curious, and with capacity comes staffing, and I understand that because you have to staff the additional beds. But I know as the pandemic first began, there must have been some kind of certification at Cook DeVos Center to expand. What is the current situation? Do you have the staffing to even expand the number of beds? What is the situation? And is that something that you are all looking at this time?
Yeah, so good question. Happy to take that. And so all of us had discussed early in the pandemic, when this all began, using Cook DeVos Center, because if you recall, this was always part of the emergency preparedness plan for the region, that Cook DeVos Center could be what's called an alternative care site. As we've learned through the course of the pandemic, that alternative care sites, like you saw in New York with the Javits Center and in Detroit, you saw many places that came up. A lot of infrastructure was built and not used very readily or very well. And what we've all learned is these acute care centers really are made much more, for alternative care sites, I should say, made much more for an acute, sudden, time-limited event, a mass casualty event where you can care for a number of people in a short period of time and then you recede. COVID is obviously anything but a short event. And so what we have determined after a lot of analysis, both looking at Cook DeVos Center and actually DeVos Place downtown, where we had our vaccine clinic with Matt, we've looked very closely, and our strong feeling, and I believe it's the same for Peter and for Matt, is that we'd much rather expand within the four walls of our hospitals. We've done that already. We have areas that traditionally aren't patient care areas that now are patient care areas. We would much rather be there, not only for a staffing standpoint, but if you think of all the ancillary support that needs to be at a hospital, pharmacy, lab, even information technology resources, that all exists within all of our hospitals. I'd much rather have a patient somewhere close to all that and have to export that and then double the infrastructure and double the staffing. So from a capacity standpoint now, our ICUs are 140% of our pre-COVID capacity. That's not just staff, that's beds.
So thanks, Daryl. I think that ties directly into this next question. And although it was addressed to me, you really did a nice job answering it. It says, Mercy's intensive care units at 100% capacity. How much capacity does our ICU have? And what does it mean for care response when we're at capacity? So, you just spoke to it. Really, the needs flex as patient care needs grow. So our ICU traditionally is a 32-bed unit that can care for patients in various levels of needs and for care. That unit is full, and we're looking at ways in which we can expand the capacity of our critical care services because there is such an incredible demand. So we're looking at how we can potentially double up patients within ICU rooms. We're looking at areas where normally we don't take care of critically ill patients and being able to provide ICU care in those areas. So as the needs of the pandemic have adapted and changed, so too we have had to adapt and change in order to meet that need. And so I hope that helps to address that question. And I think it also speaks to the notion that Dr. Hahn was mentioning that, the specific capacity number is fluid, and it speaks to what we have in terms of actual beds, but what we can also staff. And so there's a lot of fluidity to it, a lot of variability to it as the needs flex. Our next question comes from Dustin Dwyer, and it is, are there any equipment or supply concerns at your hospitals right now, especially ventilators and ECMO? I know that I mentioned in my opening remarks that we did have some very specific equipment needs. Particularly, we've added additional ventilators. We've been looking at additional specialized hemodialysis machines for critically ill patients. We just had a conversation amongst all of our health systems recently, earlier this week, where we made sure that we were sharing contact information for those that are involved in our supply chain, so that we could ensure that we could share resources in the most effective way. Just yesterday, our colleagues over at U of M Health West helped us with urgently meeting a need for some equipment that's used for feeding patients through a tube. And so thankfully, we've been able to coordinate and collaborate around scarce resource. Daryl, Peter, anything that you'd like to add on this?
Just one quick comment that probably folks would think about as we're all shopping for the holidays and finding that we don't have all the supplies in local stores and where have you, because of the pandemic and the supply chain crunch. That is happening to all of us as well across healthcare. On a normal month prior to the pandemic, we would have somewhere around 30 supplies, different types of supplies that were on back order. As of this month, we're over 700. A couple of months ago, we had over 1,000 different supplies on back order. So forgetting even the volumes we're seeing for COVID, there are things as simple as feeding pumps that Matt was talking about that we can't get enough of because the global supply chain is challenged. So that is a challenge on top of a challenge.
Thanks, Daryl. So we'll move right to the next question. I think it was your comment. The only way to get through this is vaccination. The vaccine has become a political football. Who is reaching out to political leaders opposed to vaccines, explaining the situation and that their leadership of voice matters? So maybe I'll turn that one back right over to you, Daryl.
And maybe I'd ask Rick to chime in too. We are constantly in contact with the MDHHS, the governor's office, with the Kent County Health Department, as well as all the health departments in the 16 counties that we work, apprising them of the situation, talking about all of this. And I will tell you, there's a few things that we are absolutely wanting everyone to know. Number one is the situation in all of our hospitals and how, even if it's not COVID, all care is impacted. And if this keeps going up, it's going to have more and more of an impact. Number two, as Peter so eloquently said, the only way to get through this is vaccination, particularly with these new variants. The thought that natural immunity will somehow prevent us from having troubles with Omicron, we just don't know yet, but are very worried. And then finally, we absolutely think that we want things to be open. We want kids to be in school. But what we absolutely do realize is that when you have positivity in your community that is 20+%, that people should be wearing masks. So we're trying to go out there, say, please wear a mask in a crowded public indoor space. It's, as Rick said, it's not a big ask. I know people are sick of it, so am I. But right now it's bad, and I'm hoping in a few months when it's better, we can take those masks off. So we are advocating everywhere we can. Rick, I don't know if you have any other comments from the business community.
Yeah, so we've been trying to keep the message, the data in front of decision makers and our members, and helping them understand. And again, from the very beginning, we've been talking about let's protect the lives and livelihoods. This does, we all saw the effects in the early parts of the pandemic when some businesses were completely shut down, and how that affects everyone's livelihoods and our quality of life. And we don't want to get there again. And so we've been just kind of beating that drum for the last, I guess, couple of years now. It seems hard to believe to say that, but looking at the data, looking at what works, we know what works, and just keeping the information in front of our businesses to help them share that with their employees as well.
Yeah, a couple other ads, in addition to each of us reaching out to state leaders, such as in the Michigan Department of Health and Human Services, as a emergency region 6, the health systems within West Michigan together crafted a letter explaining the situation that we were in that was covered by many of you in the past weeks. We've also been working really closely and collaboratively with our county health leaders. So Dr. London and others at the Kent County Health Department. It's important that we're working hand in hand with our county health leaders in terms of also how we're looking at and working with, to Dr. Almucci's point, our school systems and superintendents. And many have reached out to us in a consultative capacity or for advice about how to manage things moving forward. And so I think that we've been doing this as health systems across the board with both a private and governmental leadership. So the next question comes from Carolyn. How is the U.S. Department of Defense healthcare team being sent to Spectrum, that was sent to Spectrum, being used? So Daryl, I'll let you take that.
Yeah, actually, I got to meet the team this morning. They were being oriented. I honestly had goosebumps meeting them. They were amazing. So a team of 20 healthcare providers, physicians, nurses, respiratory therapists, seasoned, have done this before in other states, will actually be part of our care teams, primarily here in our hospitals in Grand Rapids, where they will be caring for patients in the ICU, on the floor, in the emergency department. They'll be starting to care for patients as soon as this weekend. So feel lucky and blessed and so thankful they're here.
Thank you for that. This next question is for you, Peter. I believe Dr. Hahn mentioned alternative care sites and areas being used at University of Michigan Health West. What are those sites, and how does serving patient at those sites affect care?
Yeah, just as an example, we have a long-term vent unit within the four walls where traditionally we have not put any acute care patients into. And so we are doing that now for the space. I think, if the surge gets much worse, within our contingency planning would be to actually put acute care patients into our pre and post anesthesia units. I mean, if they got to the point, we'd even use our ORs. So, this is all within planning. But we're trying to use spaces that we haven't necessarily put acute care patients previously, but would make sense to do that. I think another thing that we're trying to do is, we're having a lot of difficulty getting patients to short-term nursing facilities. There are patients who are on comfort care or hospice, B, and we also have a cadre of patients that we'd like to send home on the hospital at home program, but due to supply chain issues, we don't have enough devices to do that. So those three groups of patients, we're thinking through putting them sort of together using different staffing models in different areas of the organization to watch, so that we build that capacity for more and more acute care patients if needed.
Thank you for that. So this next question, again from Dustin, we're already seeing a rise in the number of COVID deaths in West Michigan. What are our hospitals doing now to prepare for more deaths? How will this compare to previous surges? And do we have capacity to handle what may be coming? Although I think we all have probably strategies around how we prepare for additional deaths and whether or not our systems can handle this unfortunate outcome of COVID. I think the greater preparation is really on focusing on how do we continue to provide the level of care that we did pre-pandemic to all those patients that are serving us. And I hope what you've heard is that we're really trying to adapt the strategies based on the need. And so as we see more patients who require critical care support, or more patients who require different levels or have different specific needs, that we're quickly trying to adapt them to avoid death as an outcome from this disease. I don't know if Daryl or Peter, you wanted to add anything.
Matt, I'll just say one quick comment. We, the month of November, so the month that just passed, saw more deaths than the month of November in 2020, even though we were surging in 2020. And based on the numbers of people in our ICU and what we're seeing in the community, we anticipate that December of 2021 will probably set a sad record for the number of deaths we've seen through this entire pandemic. So it is hard, and forgetting the challenge of caring for all those patients, the impact to all those families is unspeakable. And our team members seeing this much death, no one's prepared for that. People don't go to med school, nursing school, what have you, and expect that many deaths in that short of a period of time. So it is really a challenge.
Daryl, there's a follow-up question on that. It says, what is the death rate for COVID-19 patients? Spectrum said it was 10% in the fall. Is it the same now?
The last I saw our data was about 3 weeks ago, and we were actually just under 9%, so doing better. We think part of that has to do, as I'm sure you both are experiencing, with care has advanced a bit over the last year. We've learned a lot, but also remember, we are admitting younger, underlying, healthier people with severe COVID now. So even though they might have very rocky hospital stays and some will die, younger people will generally do a bit better than the older folks we admitted in the past. So we're seeing just under 9%, and I'm hoping that holds and goes down even, but I'm not sure.
Thank you for that. I'm going to back up and address this question from Kristen. Dr. Hahn, hopefully you can address this. Can you tell us whether patients who've gotten a booster are also coming to hospitals for COVID-19 care?
So, I think it's unfortunate that term breakthrough has been used the way it has been, right? A true breakthrough infection in a vaccinated patient is somebody who actually gets severe disease and lands in the hospital, right? And in those folks, I think what we're all seeing is they're usually elderly with multiple comorbidities. In terms of the booster, we have not seen any patients hospitalized who have gotten a booster. All that being said, right, it's not been that long since it's been available. And I just, from a clinical perspective, I think that's going to be pretty unlikely. And I think the other population of folks who have gotten vaccinated that truly get a breakthrough that lands them in the hospital, immunocompromised patients. So I think they're always going to be at a little bit more risk. If you look at the data, they make up about 40% of the vaccinated patients that do end up hospitalized. But no, we have not seen any boosted patients land in the hospital.
I totally agree, Peter. Thank you for that. I see a question a couple ahead that I think is really important that we address, and it is, are you seeing greater hostility, anger, or stress in patients? And if so, how are your staffs handling this? Darryl, would you mind getting us started?
Sure. Actually, a very important question. So I would say one of the sad outcomes of what we've all been through psychologically over the last 20 months is an amazing increase in workplace violence and hostility towards healthcare workers. The news shows a lot of this against people that work in the airline industry, flight attendants and so forth. Every single day we have a report out at the lunch hour about workplace violence issues, and every single day we hear about workplace violence. Nurses being hit, scratched, spit on, yelled at, doctors the same. It's really, really challenging and sad and so hard for our caregivers who really are heroes to face this. So I suspect you both are seeing the same, and I think this is a national problem. But as societies become more stressed, they're taking it out very often on the people that are trying to care for them.
Peter, anything to add?
No, I think well said. Yeah, it's unacceptable, tragic, and it's contributing to, I think, people leaving healthcare. People that we vitally need, not just now, but obviously in the future.
So agree with both your comments. I think this is the third crisis, if you will, that we're dealing with right now. In addition to COVID and just the contracting workforce, it's just a threat that our colleagues face on a day-to-day basis. And as Darryl mentioned, our staff are yelled at, hit, punched, scratched. We hear about these on a day-to-day basis. It feels unrelenting. It is a reason, as they both mentioned, for people to make decisions, unfortunately, to leave healthcare, sometimes only after being in healthcare for a few years. And so this is a serious issue that we're facing. And I think, as you heard from all of us, as time spent in the emergency department waiting, or as care is strained and we wait longer for care, there tends to be even more hostility and more impatience. And so I think on behalf of all of us, we'd ask the broader community for your grace, for your patience, for your kindness towards our healthcare teams, because this issue is so prominent. The next question relates to, again, staff. So each hospital has mentioned staffing capacity, supply chain issues. What is being done to address the needs of healthcare workers? Will Mercy Health or University of Michigan Health West receive any federal support? Peter, would you like to start?
In terms of actual staffing, we have not yet, but as you mentioned, Matt, I think through Region 6, there's some good coordinated effort So that I think that is a potential in the future. I know that we're doing some advocacy, especially around nursing, right? And I think nursing is really bearing the brunt of it. We're seeing a lot of nurses not only leave healthcare, younger nurses that are traveling. It's just a big need, and we're planning to do some advocacy to see if you think about after the Vietnam War or after World War II, when the country really needed, there were nurses that came, from the Philippines, from abroad, and I think we have to look at some potential long-term solutions, in addition to obviously working with our nursing schools, building that relationship. I think this crisis, if anything, has really, brought to light just how important nursing is if we didn't know it already. And so we need to figure out long-term ways to address that.
I think really well put. We too have requested federal support, but there's a lot happening in terms of how to improve the pipeline of staff that are entering into healthcare, and how do we meet the needs of those that are here in healthcare. We just spoke to how do we protect our teams from threats of violence, from the difficult work environment that sometimes they practice in. How do we address and meet their mental health needs at this point with the stress and the strain that the pandemic presents? And so, I think we're all cherishing our healthcare workers as the amazing resource that they are. The next question: at the end of the summer, we heard a few programs like testing, which used to be covered to detect COVID-19, might be expiring in September. And someone addressed what the status of these programs is. And now we're seeing more lines of cars waiting to be tested, as I did recently at the pop-up Spectrum facility on Michigan. Perhaps you both could touch on this, and I'm wondering, maybe Rick, if you would be interested in kind of speaking to maybe how some area businesses are approaching testing. Daryl, would you like to start?
Sure, we're testing as much as we possibly can, and actually, amazingly enough, 20 months in, the biggest limitation for us, aside from staffing, is testing supplies. We actually, I'm amazed still that we're struggling with this a bit. We're doing, 2,000 to 2,500 tests a day. We'd like to be able to do more, and we have no intention on stopping testing until this pandemic is in the rearview mirror, if that ever happens.
Yeah, I'd agree. I think one of the, if you even look back to spring of 2020, I mean, there was a lot of advocacy. Michael Mina at Harvard was a big one for just the need for at-home testing, right? Antigen testing. That's been, and even up till now, right? You can go to your local CVS or Walgreens, they're sold out. It's just, I think that's been something that we need to learn from. I know the administration's announced some, things that might help with that potentially, but I think at-home testing was one thing we probably, as a nation, could have done a lot better on, that would have relieved some of this.
Yeah, and I think from the business community is experiencing some of those same challenges, right? They're wanting to make sure that they're creating an environment that's safe for their employees and their customers, and running into some supply chain issues to be able to do that with testing. But they've, quickly stood up some safety protocols, at the very beginning of this, and many of them, and most of them, are still using those protocols to make sure that they're creating a safe environment, for their employees, and being a part of the solution, not part of the problem that we're dealing with.
That's great. Really appreciate that. Looks like one last question. Wondering if, I believe it was you, Daryl, said, I wish we could give tours and walk through our ICUs. So the question is, describe in as much detail as possible what you saw the last time you rounded in one of our ICUs or emergency departments. We're struggling to describe something that none of us out here are able to see for ourselves. So maybe we could all take a stab at this. Go ahead, Daryl. You want to start?
Sure. I'll just describe a recent rounding experience I had. First of all, rounding in an area that traditionally was not an ICU that now is. So that's very different. Number two, and I'll just say the theme, tears. really tears from our team members who just have been burning the midnight oil, seeing so much death, taking on extra shifts. And then honestly, the last time I rounded, tears from a family member that was about to lose a loved one. And I believe that person was far younger than I am. And so this is happening every day, over and over again at all of our hospitals. It is not a pretty sight. It is not something any of us wish upon anyone. And the best way for this to end is for us all to be vaccinated and follow those simple things that we're all absolutely sick of.
Yeah, I'd echo that. Just, rounding in the ICU or ED, even wearing a mask, you can tell from the eyes, right, what's going on. And yeah, there's tremendous stress, tremendous heartache, but there's also, courage. And I think at all three of our organizations, people are stepping up, they're doing the right thing, taking care of patients, but it is difficult. And this round is definitely the most difficult for a variety of reasons, but yeah.
Echo the same comments. We see in COVID care, often IV poles pulled out of rooms to make it easier to exchange bags. We see isolation carts lining the halls, nursing staff in, fully donned in PPE, oftentimes expressing frustration at a situation or the tears of fatigue from having to deal with long hours, a number of patients, or just really difficult situations. And these are hard visuals for us, knowing the impact this has had on our teams. So I appreciate you asking the question. Thought maybe we just wrap with just any closing thoughts. Maybe we could quick start with you, Rick, and then Daryl and Peter.
Yeah, thanks. Again, thanks for allowing me to be a part of this. And I'll echo one more time a big thank you to the healthcare community for all the work that you're doing to treat our friends and neighbors and relatives in this very challenging time. We're here as a partner, the business community is a partner with all of you in advocating for the supplies that you need and trying to come up with solutions. We've come up with a lot of solutions here locally to help address some of the supply chain needs. So we'll stay with you along the whole way.
Thanks so much, Rick. I'd like to thank Matt for hosting us and all of you for being here and hopefully getting the word out even more. And ultimately, I think the respect we all have to give to our caregivers, to the frontline clinicians that are caring for our loved ones, our communities. If you have that respect, if you really feel something for them, even if you're done with all of this, like so many of us would like to be, please, please, please consider getting vaccinated. If you're not, please consider wearing a mask in a public space, even for a little while. These things will show respect to the caregivers and hopefully get us out of this.
Yeah, no, thank you, Matt, for hosting this, and thank you, Daryl and Rick. No, this is a tremendous challenge, obviously, but we'll get through it, right? I think the teams will get us through it. Just have to hold steady, and everyone's in it together, and we appreciate that.
Thank you for that. A similar message: if you know a healthcare worker, check in with them. Tell them you support them, thank them for the work that they've done, demonstrate that you care, by wearing a mask when you're out in public. We all ought to be doing that indoors at this point in time. And then, secondly, I would say we need to remember, that old adage about an ounce of prevention. So, we have to, amidst all of this talk about illness, we have to remember the notion that we have to take care of ourselves and get the rest that we need, get the exercise that we need. It's still important to eat a healthy diet. One of the things that we mentioned was just how we see more severe disease because of comorbid conditions and other medical conditions. So let's make sure that we continue to focus on health amidst all this focus around illness. I would really like to thank Rick, Peter, Daryl, you guys joining me this afternoon and talking through this really important issue for our community. Thanks to all from the media for helping us articulate the issues that we're facing to the broader community and keeping everyone informed, including the importance of continuing to follow public health guidance. So thank you all so much. Be well, be safe.